I think the biggest thing that this pandemic has proved to us is we're more capable to move forward and to evolve in ways that really we never thought were possible. And I mean that, one from, I think, a healthcare organization, one from a healthcare professional, as an infectious disease doctor, and I think also just as a human being. There was, when I thought about, well, looking back, what was my thought process? And I really feel there's probably some type of protective, innate ability in us that says, yeah, it's not going to be that bad. And I'll be honest, I recall thinking that when I first started hearing about this idea of, a communicable, highly infectious, potentially deadly respiratory illness that we knew was kind of, circling around China. And, I really did thought, well, it's fascinating from an infectious diseases standpoint. But, again, I think, it's just who we are as human beings that you think, well, it's never really going to be something that will affect us. And boy, was I wrong, obviously, in that thought process. Initially, there was probably more questions than we knew what to do with in terms of what don't we know? Where is this coming from? How do I protect myself? How do I protect those around me? What can I do if I do get the virus? Should I go to a hospital? There was, I think, every question imaginable. So initially, I think we were taking the thought as, okay, well, we really have to sit down and start targeting kind of our highest yield questions to protect our community, to protect, our patients, and obviously to protect our staff. So protection, was always, and safety was always the first priority. And it makes sense coming from a healthcare organization.
Was that because there was a sense of how deadly it was, or?
I think it was because there was a sense of the unknown. There was still, again, when in medicine, that's what we do. We take peer-reviewed, scientifically based, solid evidence, and we dissect it, right? And then from that information, we take that and we use that to practice medicine, and we use that as guidance to educate the public. And in the beginning, we didn't have that, and that was challenging. Because again, I think we were trying to scramble to a point to say, okay, we kind of have to stop and pause and figure out, what do we know? What do we know so far that is solid, scientifically based evidence to say we're making the right decisions for our community and for our patients and for our staff? And masking was probably one of the first where we thought, okay, yeah, this makes sense. Because if you remember, there was a lot of, and I don't want to use the term flip-flopping, but I think there was just a lot of uncertainty, even from, reputable organizations like the CDC saying, no, you guys don't need masks. And then come to find out just, a few weeks later that, well, perhaps you do. So one of our biggest lessons was getting the staff in tune with the idea that sometimes what we say in the morning might change in the afternoon, and then it may change again in the evening. And it's not because we don't know what we're doing. And it's not, we don't ever want you to lose confidence in what we're saying. It's just because we're looking at the information and we're evolving.
Well, part of that was that originally, there was this rush on masks that, and everybody was saying essentially, we don't want the community to have masks because we want the healthcare workers to have masks, because they're the ones, who are around the disease the most. And, there was some discussion like about how, the masks won't protect you from the virus, especially if they're not N95 masks.
Right.
That, and then, as they watched what, other countries were doing, particularly, I think, South Korea, they realized, well, it's not about keeping the germ away from you, but if you have the germ, keeping it away, blocking it from getting to other people. And that was kind of how it evolved. The masks evolved into something that protected others, if not necessarily you.
Yeah. And it's a good example, I think, of the evolution of COVID, just using one topic as a mask, like you said, and how initially there wasn't a thought. I mean, I'll be honest, I could remember coming in and, we were masking obviously around patients that we were concerned about, but was this their idea of community masking? Was this their idea that you have to walk into a workplace and have a mask on? It wasn't there in the beginning.
Right.
And then obviously shifted to, well, no, perhaps this is something that we all should be doing at all times. And then as the information evolved, it was, well, there are different types of masks, and, masks do different things for different purposes. And you're right, hospital grade masks really should be reserved for those in the healthcare community versus other types of masks. And now we're CDC as of yesterday came out and said, maybe, we should be wearing 2 masks at times.
Right.
So, it's funny that you could perhaps just make a story about masks being, the prime example as to, how things changed. But I think the story of, how things are changing again is to speak to us understanding that you have to take information and you have to evolve. So, to the public, it may have seemed that there was uncertainty at times, or that people didn't fully understand it. That's not the case. It really was, information was coming in, and we had to, learn how to dissect information in a totally different way, because it was new, and we had to understand is what coming in reputable, and make decisions based on that information to guide, again, the public, and to divide, our staff. So we've never really done anything like that before.
That's exactly right. Yeah, because I remember, and I've read this, is, a century ago, you go back and look at the history of the Spanish flu pandemic, and you see that people started wearing masks, but we haven't done that since. We never did. We didn't know masks were a good idea. Like, we found that out through trial and error, like in the last, early, after a couple of months. Was there any evolution in diagnosis in terms of, understanding the differences between whether it was COVID and of course, testing was part of the problem early on too, in terms of understanding whether it was COVID or whether you're dealing with just the flu or some other coronavirus,
Yeah, absolutely. I think we being just, in the present day community, we were in a different space than we were perhaps in Spanish flu, again, just because of technology. So when, this idea of a respiratory virus came out over in China, it actually didn't take that long for them to understand what is the genetic code of this. And we already have the technology in place, here in the United States to do what we call PCR testing. And it's funny, I think you can ask some of your, the community too, that if you asked them a year ago, do you know what PCR testing is? They would say, a what? And now, most people can probably speak to, well, sure, I know what that is. That's a type of COVID test, and it detects the genetic material. So we had PCR technology. It's something that is extremely common in all health core organizations.
No, I did not. Okay, I didn't realize that. Okay.
Yeah, across the United States. So again, the technology, was something that was already known. And it's, how we detect if you had, rhinovirus, if you have influenza, it's the same type of technology that's used.
Oh, well, so that explains why, even though they had a delay in unveiling the test that worked, we were able to quickly get a test that worked.
Right. You needed to get what we call the primer, which is basically, this is the code that when I put your sample, whether it's from, a nasopharyngeal or sputum, when I put your sample into the instrument, if that genetic material is present in your specimen, it's going to hit the primer that I have in my instrument. So we needed to add that primer, basically. We had influenza primer, and we had rhinovirus and RSV. Yeah. Now we have the SARS-CoV-2 primer. Okay. Geisinger, interestingly, was one of the first, one of the top, I'll be honest, right, within Pennsylvania to say, we're going to get that primer, and we're going to have this test available.
That's right. You had one of the few labs in hospital in the state.
Yeah. And, early when this first hit, we weren't necessarily in an issue with not having the technology. We were in an issue with not having supply. And again, that wasn't anything to do with Geisinger or Pennsylvania, or it was just, again, because things were new and they were getting pumped out, and there wasn't a lot of organization as to how different supplies were going and how resources were going to different areas. So I can even remember thinking, earlier on, like, I have a couple of tests, and what do we do with them? Who do we use them on? Who don't we use them on? And now you look to where we are. I mean, we have, you can go online on our website and you can, with a few clicks, go through, and I'll give you a date and a time for a test this afternoon that's, close to where you're.
Oh, that was a huge issue, just getting tests. Yeah. Because the hospitals were screening for, do you have symptoms? And, there were probably a lot more cases for that reason, because, people either had mild symptoms or didn't present any symptoms, and what, hospitals were telling those people, just stay home and, monitor your symptoms. It gets worse, call us,
Yes.
Yep.
And then, as more people in the scientific community got interested in testing, that was the idea, well, then, this is challenging, because not all hospitals maybe have the amount of instruments you need, or not all hospitals can get these types of supplies in. So can we look at, and they started talking about these point of care tests. So that's the type of test that basically eliminates the use of a lab. So you started seeing things like, oh, there's a saliva test. I can order something online and I get a kit delivered to my home, and all I need is simple saliva. And, I put my specimen, in this little tab, and it will tell me within 15 minutes if I have COVID or not. And, that I think was an interesting development, for maybe even in the future, things to come with testing at home, or this point of care testing. The downside to that type of testing is obviously it's not as reliable.
Yeah.
It's not as accurate as a PCR. But certainly, again, it kind of expanded the scientific community in a laboratory way, in a way that we've never really thought about before. Because again, if someone's sick, you come to a hospital. The idea of coming to a hospital during COVID was something that was frightening to some people in the community. And, there were times that we were in, a crisis situation because of our capacity. So I thought that was a very, something very fascinating from the lab side, to think that we're looking at different ways to delivering test results, or even obtaining test results in a way we've never done before, in your own home.
And it's not an issue anymore. It's like, pretty much testing are abundant now. Like, there's somebody testing somewhere all the time. Like, I don't know how much they screen anymore. I mean, there's organizations that don't screen, for symptoms like they did early on.
Yeah. Yeah, and I mean, testing's different now too. Like you said, you need, in Pennsylvania, we're one of the states that requires, if you travel out of state, for more than 24 hours, well, we're going to need that testing upon return to the state.
Right.
So like you said, it's evolved in so many different ways that, you couldn't even imagine, a couple of months ago.
How about treatment? Because there's a whole lot of hocus pocus early on about what would work and what didn't. Remember what was it, the particular one that everybody was saying, that old quinine?
Hydroxychloroquine.
Yeah, right. Yeah, that it was, how effective it wasn't. There was anecdotal evidence that it wasn't. I guess overall it turned out not to be as effective as everyone thought. But so can you talk a little bit about the evolution of the treatment?
Yeah, sure. Initially, again, there was a lot of talks on some of the anti-inflammatory medications, so some of the hydroxychloroquine, so medications that were currently being prescribed for different uses. Some of these uses being non-infectious, in origin. So the hydroxychloroquine is probably, one of the most common that people would be familiar with. And, it was something that we did. We had it on our policy here. We had it on our protocol. And again, what was very challenging from a medical standpoint was we didn't have the rigorous, perfectly designed studies where we can say, well, look, we have 10 years of data that hydroxychloroquine helps individuals with, COVID-19 versus 10 years of data where it says, no, it doesn't really do much. So, perhaps, there's no benefit to giving it to them. So it was really it was interesting. It was more of a collection of discussions, both nationally and internationally, with large scientific communities. A lot of it was grassroots discussions that were just being put together by physicians, by infectious diseases docs, by critical care docs. I had trained in New York City, and I had colleagues that were still practice there, and they were really the epicenter of the pandemic, several months ago. And there were multiple discussions that we pulled together, big Zoom calls, and we talk about, let's talk about what you guys are doing there, what's working. So it was really fascinating to see, the everyone collectively pulling together, and you have one unified effort, which is we need to stop this, and we need to figure out how to help people that are getting it. And that's really what led to the solving of the problems and the solving of the issues. It had to be bigger than one person. It had to be bigger than one hospital. It had to be bigger than one organization.
And there were, there were treatments that evolved out of that. The Dexa, I can't remember.
The dexamethasone.
Yeah, that was one that became fairly effective in terms of, catching the virus at certain stages. What else?
Yeah, the dexamethasone is interesting because it's a steroid, and
right.
It's an anti-inflammatory, so it doesn't have any antiviral property. But we started to learn fairly quickly that this virus was affecting the body in ways that other viruses, we didn't really see that common. Meaning, we understand that respiratory viruses can have a lot of local effects on the lungs. But COVID was acting a little different. We were noticing a lot of other end organ damage with this virus. So it wasn't just, localized to the lungs. We were noticing individuals coming in with some, CNS disturbances, some with renal, with liver disturbances, with blood or coagulopathy issues. And we also noticed a massive inflammation response. So that's where the idea of the dexamethasone, came into play, and it proved to actually be a tremendous mortality benefit.
What's CNS?
Oh, sorry, the central nervous system.
Oh, okay.
So anything, brain related or neurological related.
What other treatments? The other shortages that existed early on were ventilators, right? In some places, like I'm not sure how that affected Geisinger, but
yeah, and it did. So we never, thankfully, ran out of ventilators, but we had to devote a lot of time and a lot of resources to sit and plan, because we realized with COVID, you can never fall behind. You always want to try to be one step, if not two steps ahead of this. So the planning, for scarce resources, that started pretty early on, I'll be honest. And thankfully, we never had to pull the trigger, on any of those plans that we had in place. But we certainly made sure that we were never going to be in a situation where we didn't have them available. Did
you have to go out and acquire more ventilators? You did, okay, yeah. Were there resources for that, or the places you could go to, they were available, or was it pulling them from other hospitals, or was there the manufacturing capability for it? Or?
I'm not that close to this, to the work of the supply and how they're acquired.
Yeah.
But, we were in a unique situation too with Geisinger, where we have a large system.
Right.
So if we had the Northeast area that was really surging, we were able, to make sure that we shared, the resources that we had in the central region.
Yeah.
And what was really great to see was later on in the pandemic, not only did we do that within the Geisinger system, but all the healthcare organizations came together. So we currently have a large collaborative group with all the hospitals. And I mean, this is talking about, those in Scranton, with regional, with CHS.
Mm-hmm.
This is all the way extending out to the central region, where we still meet and we share success stories. We talk about things like you said, like resources. We talk about, what are our critical care capacity needs in the event that, we're running short on one organization we're going to make sure that, us being right next to you in the community, that we help you out. So, those boundaries of, you're one system and we're one system, those walls came down. And again, it was just very powerful to see, and great to see we're still doing that work.
Yeah. What you mentioned and you said the dexamethasone was a real factor in curbing the number of deaths?
Correct. Yeah. It was really the first great drug that we had that showed that there was a significant mortality benefit. Now, again, it's for a select population. It's not for somebody that's, out in the community, and it's not those that are coming in that are, don't need critical care level. So it's people who meet certain oxygen requirements or have a certain degree of lung inflammation. Yes.
And is that because they were noticing, you mentioned the organ damage, and steroids are a typical way of improving, correcting organ damage?
Yeah, steroids help with the inflammatory component of COVID.
Okay.
So what we were seeing is some patients get COVID and you feel, it could be a range. You can feel nothing to, I feel like I have the flu, all the way to I need to come to the hospital because I can't breathe. Some patients get COVID and they go on to recover really with no issues. And others we were finding were really recovering from the viral aspect of it, but going on to develop this inflammatory component where basically your immune system goes into overdrive.
Are these these are the long haulers? Is that what we're talking about? Yeah.
A little
different
than the long haulers, a little different, but it was just a unique damage to the body that started from a viral process, something that we wouldn't see with influenza per se.
Yeah.
So again, patients who meet the criteria for dexamethasone, they have to fall into certain parameters. It's not just anyone and everyone, but it's those that we know are heading towards that inflammatory component where we want to start shutting down the inflammation.
Were you surprised, and listening to the people at Moderna talk about how they developed their vaccine? Were you surprised at how quickly they were able to, develop the vaccine? Was everybody really expecting that, in typical terms, this is going to take a year to 18 months? That was the number we heard all the time, a year to 18 months to develop a vaccine. And here we had it 9 months later,
If someone said in March that 9 months later you'd be sitting there talking about vaccination distribution, I'd say you're out of your mind. I really would. But it's unbelievable what was accomplished. And I don't want to keep going back to the idea of what could occur when individuals collectively unite for a common cause. But that's exactly what Operation Warp Speed was. It was stacking of hands. It was stacking of hands of pharmaceutical companies, of the government. Basically, it was pretty fascinating what was done. They didn't skip any of the safety steps. So all of the rigorous testing and standards that are in place were done. But what happened historically in the past with vaccine development was it cost a lot of money. I mean, it's a financial risk for pharmaceutical companies to put out a drug that potentially will fail. So it happens in slow phases. And once they say, hey, look, this phase looks great, I think we can start pushing things through to phase 2, let's recoup some more money. Basically, what Operation Warp Speed allowed was for phases to happen in parallel. So they removed the financial risk. Now, clearly, if you look, there was hundreds of people in the game. We have two. We have Pfizer and Moderna. Yeah. So, not everybody made it through. Not everybody showed the safety, showed the efficacy. But again, putting literally billions of dollars into this, removed that financial risk and said, guys, we're going to work with you. We just want to make sure something gets out, that we get it safely and effectively done. And they did.
You're talking about the federal government investment, the help. Okay. I wanted to ask a little bit more about, were there experimental treatments along the way that didn't work? The thing.
Yeah, and I think the, experimental treatment, I don't know if I love that word per se.
Well, yeah, well, I'm just saying this, you're in a panic. Well, I don't want to say you're in a panic because doctors are pretty cool customers usually, but you're up against this virus. You don't know what's going on,
Yeah.
and you're more willing to try different things, just
Yeah.
to you have a patient in front of you, you want to help them.
I would say that, and I can't speak for every organization, but, everything that was done here had data and science behind it, and we would follow that science. Now, if it panned out, for example, hydroxychloroquine is a perfect example, that when we started to see more robust studies come out and they said, guys, like, I don't really think this is doing anything, then yeah, we would reevaluate our policy.
Geisinger was actually using that for thinking that it may have some effect, but then
Sure.
finding out they didn't. Okay, all right,
Sure.
interesting.
And yeah, there's been a couple of drugs that have come down the pipeline that, I mean, literally thousands of studies out there that, they said, let's try this medication. And again, everything has been done as following the same standards that any other medication would have to fall under. And like anything else, some drugs show benefit and others unfortunately don't. So you kind of say, okay, let's end this and let's move on and find something new.
Is there anything besides the Dexa that works?
Yeah, so
I think I've heard people, prescribe prednisone at times.
Yeah, we have a couple of different treatment regimens in our protocol, depending upon the scenario, depending upon how severe the infection is, and so we do use convalescent plasma in some of our inpatients. So that's basically somebody who recovered from COVID, a natural infection. They can donate their plasma, and from that plasma they pull antibodies, which is basically the really good protein that protects you from COVID.
Mm-hmm.
And then that plasma with the antibodies can be used as an infusion into patients. So again, this is something that I'm trying to think of what, similar to a blood transfusion. So all of this is done kind of outside of Geisinger. We don't do any of this internal. And if a patient, meets the criteria and they consent to a transfusion, we can administer antibodies to them. We also have something called monoclonal antibodies.
I was about to ask about that, but I was talking with Dr. Keith yesterday.
Yeah. And that's kind of fascinating because this is hitting a different type of patient population. So this is reserved only for those who are not hospitalized.
Right.
So the idea of this is to keep you out of the hospital. So I loved, when we started getting more information about monoclonal antibodies, because it was like, great, like we're getting one step ahead again. We have something that we can pull out of our toolbox and use in these outpatients in an effort to prevent them from coming in. Now, the data is still fresh. We don't have a lot of information in terms of, time from this, but I could tell you even within Geisinger, we are noticing that those that are receiving monoclonal antibodies, they're really not getting admitted to the hospital.
Yeah.
Requiring that admission. So it's very promising, but like anything else, we have to wait for the study results to come out before the decision is made to keep it on.
I want to talk about a little bit about the future, but I want to ask one more question. And that is, are you seeing the effect of the vaccines yet?
Yeah, and I can tell you, even within Geisinger, we're seeing it.
Just
so
fewer of your workers getting sick.
Yes. I mean, and it's pretty startling.
Oh, really? Yeah.
Yeah, the numbers. And there really is a strong temporal relationship to when we were able to start getting our staff vaccinated. And then just a couple of weeks later, starting to see those numbers drop of our own employees contracting COVID. So yeah, we've definitely felt the benefit of it.
Well, there's been a lot of talk, that now that we've been sensitized to the possibility that this could happen again with some new virus, and not that virus will be exactly like this one, but I imagine there will be similarities. What do you think in the long term we've learned that would be helpful next time?
Yeah, I think no doubt there's a lot more understanding of the importance of emerging infectious diseases. And this is something that is far above us. It's far above the community level or even, the state level. But back to the federal level, that, we have to make sure that resources are in place. And that I should say that the support is in place for these resources and the funding is in place for emerging infectious diseases.
PPE and all that other stuff, like that was a shortage early on. Yeah.
The PPE, correct. Yeah. And we have we don't have the most robust surveillance system for monitoring, certain viruses. And I can start to see already how that idea is picking up, and that this is something that we really should be doing. And when I'm saying we, I mean, as a nation. So
contact tracing, that kind of thing.
Yeah. So basically the idea of, if you have, a viral swab for SARS-CoV-2 for COVID, here at the United States, it's a reportable infection. So as soon as that positive hits the lab, it has to get reported up, and that's all reported to the state level, and that goes up to, the national information. Other countries, in addition to making sure it was reported, were also doing surveillance for different variants and different strains.
Yeah.
And I think that, it's extremely important for obvious reasons that's something that we're tracking within the United States. The UK, for example, has a robust, surveillance system to monitor for different variants. Hence, they were able to kind of let the entire world know when they started seeing the UK variant. Same with the South African variant. So we're starting to really pick up on that understanding here in the United States as well, to say, guys, like, we have to be on the lookout for this. So we do, even within the Geisinger system, we have a monitoring system in place that if something doesn't, seems off within a certain viral sample that we're running on an instrument, we're making sure that we're sending that for sequencing. So that we can detect any different strains or variants.
Oh, really? Oh, so that, like, if a new virus were to come along, you might notice it now, like and maybe you weren't quite to that level.
We always joke and say we don't want the northeastern Pennsylvania strain of COVID, but if there is a strain, we're going to make sure that we find it. So we're being proactive in that sense, which is important.
I'm just thinking also that it's pretty clear that masks work. They have an effect. There's still people who will dispute that, but I think there's scientific evidence on that is mounting. I think it's pretty clear that if you don't get together with a lot of people, you stay isolated. That works. And that the next time around, people are going to say, okay, mask up. Isolate. That maybe there'll still be people, and there probably will, because right now we're going through this fatigue. So it's almost a year and we're tired of this and we don't want to do it again. But next time we're like, all right, we did it once, these things work, and we know that we won't have to be teaching people that masks works, and we don't have to be teaching people that to stay away from each other, keep social distance, things like that, which were like almost a mantra for Rachel Levine early on, like in her press conferences, every day, wash your hands. As long as it takes to sing happy birthday twice, I'll never forget that. Those kind of things, but I mean, we saw in the last decade a number of different viruses emerge, and this one is obviously the worst. There's no way to predict what will happen, but do you think we're going to see more like this?
It's a fascinating question. And like you said, I don't know if anyone has the answer to that, but I certainly feel more comfortable and can sleep a little better now than perhaps we could a couple of years ago. Because again, I think that there was just an overall greater understanding of why we really need to kind of have our eye on the ball of any new emerging infectious diseases. And, I would hope that our guard doesn't get let down even in a few years from now. The lessons learned should be continued through. So definitely in a much better place where we are now than we were years ago. So the hope is that if something does start to emerge or pop up, that we're on it sooner than later.
That was excellent.